Let's now talk about meglitinides. So this is another anti-diabetic drug, and this one is really similar to sulfonylureas, but it's basically a rapid onset and short duration of action drug. So we'll talk about the mechanism of action, some aspects of the pharmacokinetics, adverse effects, cautions, and the suitability of this drug. So starting by the mechanism of action, like the sulfonylureas, this drug will act by increasing the insulin secretion. And how? The same way as sulfonylureas. Basically, it will bind to the beta cells, to the potassium channels, specifically on the SUR1 receptors, but at a different site than the sulfonylureas, with a little bit of less affinity as well, but basically the outcome is the same. It closes the potassium channels, there is the membrane depolarization, then calcium enters the cell, which leads to ultimately insulin secretion. But basically, this insulin secretion only occurs in the presence of glucose. And this drug is a postprandial glucose regulator, so it should always be taken along with meals. So normally, ideally, because it has a rapid onset, it should be taken 30 minutes right before the meal. So when people eat, it does its effect in decreasing the glycemia, and it will basically last around 1 to 2 hours because it's heavily metabolized by the liver. Okay, so side effects, adverse effects, they are basically really similar to the sulfonylureas, since the mechanism of action is very, very similar. So they can promote hypoglycemia and weight gain as well. However, these effects are less marked than with the sulfonylureas, again, because they have lower duration of action. Also, they can present gastrointestinal effects like abdominal pain, diarrhea, constipation, nausea, vomiting, and more rarely, some patients may present hypersensitivity reactions and elevation of liver enzymes, but again, a very small number. Some cautions to keep in mind with this drug. So, not to be given to severe hepatic or renal impairment, again, because it's metabolized by the liver, it's excreted by the kidneys, and we don't want just the drug to be hanging around in the body. We want to get rid of it at its normal times. Also, avoiding pregnancy, like we discussed on previous videos. In pregnancy, normally the drug of choice to treat diabetes is insulin. Take into account that beta cell function will deteriorate with time, and this drug will only act if the beta cells can produce the insulin, they can synthesize the insulin, but if they don't, if the beta cell function deteriorates, then there is no point in giving this drug to secrete it because the insulin is not being produced properly. So once this happens, patients should actually start on insulin to control the diabetes. And lastly, corticosteroids and Tsi Diuretics, they can decrease the hypoglycemic effects of these glinides. So this drug, we know that is not as widely prescribed like metformin, which is the first line, but why can it be beneficial? It can be really beneficial in patients with postprandial glucose elevations. So for those patients that they really struggle with their hyperglycemia right after the meals, then this is a good option just to get those sugar levels right after the meals. Okay, that's it for today.